Good morning, everyone. Welcome in. We'll get started in a couple of minutes. Good afternoon, everybody. Get started in a few minutes here. Hi, welcome, everybody. We'll get started in just about one more minute. We have a very packed schedule for today. Okay, I'm gonna go ahead and get started just because we have two presentations for you all today. And just as a reminder, these will be recorded and available to everybody later. So if anyone does miss any of the beginning of the presentation, we'll send this out shortly. So good afternoon, everybody, and welcome to lecture 3 of the Upgrade Oncology digital training for nurses and clinical oncologists. This training is brought to you by Project Pink Blue in partnership with BioVentures for Global Health and funded by the ACT Foundation and the Nigerian Federal Ministry of Health. We're really pleased to virtually welcome everybody back to today's meeting, and it's great to see all of you again. Before starting the program, I just want to go over some brief Zoom etiquette again. Just as a reminder, we are in a webinar format, so this means that your videos are turned off and your microphones are muted by default. So if you have any questions throughout the webinar, please add them either to the chat function or the Q&A function at the bottom of your screens. And I'll go ahead and share those questions with our lecturers at the end of the session. And because we have 2 lectures today, please add any questions for either section to the bottom of your screen, and I will share all of them at the end. Just as I was mentioning, we'll be recording this session, and the slide deck and recording will be made available to all registrants. And if you have or need any help operating Zoom or having any issues, please reach out to me directly. I'll put my email in the chat as well. Now it is my pleasure to welcome our 2 presenters for today. We'll be welcoming back Renee Wisniewski, who we had the pleasure of having with us last week. Just as a reminder, Renee works as a palliative care nurse practitioner, providing care to oncology patients at Memorial Sloan Kettering Cancer Center. She is an adjunct professor with the New York University Rory Myers College of Nursing. Renee graduated from NYU College of Nursing with her Bachelor of Science in Nursing and Master's degree. She studied at the University of Colorado and obtained a Bachelor of Arts in Anthropology. She has published articles on nursing communication strategies and primary palliative care in nursing. We are also joined today by Venessa Battista. Venessa is a board-certified pediatric nurse practitioner and currently serves as the Senior Nurse Director of Palliative Care at the Dana-Farber Cancer Institute. Previously, she practiced as a PNP on the Pediatric Advancement Care team at the Children's Hospital of Philadelphia and was a clinical faculty at the Boston College Connell School of Nursing, where she developed Pediatric Palliative Care Master's subspecialty program. She earned her bachelor's degree from Boston College in psychology with minors in health sciences and faith, peace, and justice studies, her nursing degree and master's degree from Columbia University School of Nursing, and completed a certificate in pastoral ministry at the Boston College School of Theology and Ministry. Dr. Battista obtained her Master of Business Administration and Doctor of Nursing practice from Johns Hopkins University. So we are so happy to have everyone with us here today. And with that, I will go ahead and stop sharing my screen. And Renee, I'll go ahead and let you share yours.
Great. Okay. Thank you so much. And it's a pleasure to be back. I'm so happy to see so many of you returned, and hopefully there's some new people. Today, I just wanted to, I'll be talking about pain management, especially for elder patients. To start, some objectives for today. Okay. Sorry, let me just see if it's, I apologize. There we go. Review a definition of older adult patients, identify changes that occur in older adults, review issues that impact pain management in older adults, define various types of pain, discuss pain management strategies specific to older adults. So initially, let's start with, how do I know how old you are? Who is old? What is the definition of old or elderly? So according to the United Nations and the WHO, a person who is over the age of 60 is defined as old or elderly. However, families and communities often use other sociocultural references to define age, including family status. Are you a grandparent, a great-grandparent? And that can be different ages depending upon how old you were when you first had your children, physical appearance, or age-related health conditions. So the number doesn't necessarily match up always with how you look. So older patients, according to the WHO, in 2019, the number of people aged 60 years and older was 1 billion. It's projected that this number will increase to 1.4 billion by 2030 and increase to 2.1 billion by 2050. So this increase is occurring at an unprecedented pace and will accelerate in coming decades, particularly in developing countries. This historically significant change in the global population requires adaptations to the way societies are structured across all sectors, including how we provide care. Of note, elderly adults between the ages of 60, 65, and 74 years old are considered youngest adults. Those between ages 75 and 84 years are considered middle old, and those aged over 85 years are referred to as the oldest old. I apologize, there seems to be a lag time in my slide deck. There we go. So some changes that occur with aging. Physiological changes, often the first signs of aging occur in the musculoskeletal system. Muscle mass and muscle strength tend to decrease with age, and that starts much earlier, around age 30 years, and continues throughout life. Eye changes also begin in midlife, and changes in vision can make seeing in dim light harder, impair depth perception, and make focusing on close objects more difficult. Age also causes changes to the lung tissue. Lung elasticity and the chest wall compliance decrease, and this contributes to respiratory muscle stiffness. So the lungs become less able to fight infection, partly because the cells that get rid of any debris containing microorganisms, clear the airway, are less able to do so. And cough, which also helps to clear the lungs, tends to be weaker. More changes that occur with aging, what we all have to look forward to. Most internal functions also decline with aging. So stress caused by aging can contribute to organs such as the heart and blood vessels, urinary organs such as the kidneys, and the brain to malfunction. The liver tends to become smaller because the number of cells decreases and there's less blood flow through it. So liver enzymes that help the body process drugs and other substances work less efficiently. The decline in function means that older people are less able to handle various stresses, including strenuous physical activity and extreme temperature changes in the environment. The overall decline in organ function also means that older people are more likely to experience side effects from drugs. Older adults also tend to have an increased threshold for pain, however, a decreased pain tolerance. Sorry. I'm having some issues. Okay. Sorry about this. I'm actually going to stop sharing if that makes sense.
Yeah, would you like to try re-sharing the PowerPoint?
Yeah. Sorry about that, everybody.
Oh, no worries.
Okay.
And just so you know, Renee, it looks like what we're seeing is the desktop PowerPoint and not, is that intentional?
Yeah, it was even slower with the PowerPoint. Yeah, the slideshow. Is that okay for everybody?
Oh yeah, no, it looks just as clear. Just wanted to make sure you knew that.
I'll just clear out some stuff. Okay. And then, so again, older adults tend to have an increased pain threshold and a decreased pain tolerance. So they're able to tolerate more pain. However, when they experience pain, they're able to tolerate it less. Older adults are less likely to label a sensation as painful, but when painful sensations are present, they can have negative effects such as depression, insomnia, or a change in mental status. So pain also can affect younger people the same way, but the big change that we do see is change in mental status among the elderly. And then unrecognized cognitive impairment can also interfere with pain assessments. Okay, so sorry, I skipped ahead there. There are some pharmacokinetic changes that do occur in older patients. So just a review, pharmacokinetic refers to the activity of drugs in the body over a period of time. That includes the processes by which drugs are absorbed, distributed in the body, and localized in tissue, and then excreted. So aging impacts the liver, and the decline in hepatic blood flow, gastrointestinal motility, lean body mass, liver enzyme activity, and renal function can cause changes in how drugs are absorbed and excreted in the elderly. These changes may lead to medications having longer effects at lower doses. And because of these changes, older adults are significantly higher risk for adverse effects from drugs. So basically what this means is there can be an increased volume of distribution of a drug, and that can result from the proportional increase in body fat. As we age, we tend to have more body fat, less lean muscle, and that's part of the natural aging process. Also, a decrease in drug clearance may result from the natural decline in renal function with age. That's separate from even if the presence of renal disease. So we naturally have a decrease in renal function with age. So larger drug storage reservoirs and decreased clearance prolong drug half-lives and lead to increased plasma drug concentrations in older adults. So oftentimes when you administer drugs to older adults, they'll stay in the system for longer and tend to stack. So you'll have more of an effect for a longer period of time. I just wanted to review some definitions of pain. There are a lot of different types of pain that the body can experience. I'm just going to focus on physical pain. It's referred to as an unpleasant sensory and emotional experience that's associated with or resembling that associated with an actual or potential tissue damage. So various types of pain include and are not limited to. So this isn't a comprehensive list, but we'll be discussing some medications that we can use to treat these types of pain. Neuropathic pain, pain caused by a lesion or disease of the somatosensory nervous system, such as phantom limb pain. When somebody loses a limb, there can still be an experience of neuropathic pain. And peripheral neuropathy, oftentimes oncology patients, diabetic patients will experience peripheral neuropathy. The sensation associated with, or the adjectives that people use to describe neuropathic pain can be shooting, stabbing, burning, zinging, kind of anything electric. I tend to think of as neuropathic pain. Nociceptive pain is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors, usually a result of external injuries. So it can be if you get punched or if you have a fall, it's sharp, aching, throbbing. Those are adjectives that usually are associated with nociceptive pain. Radicular pain I included because oftentimes elderly patients or older patients will experience radicular pain. It's pain caused by irritation of the sensory root or the dorsal root ganglion of the spinal nerve. So it's like a pinched nerve, which can result in the decrease or compression of our vertebrae. And often adjectives people use to describe this type of pinched nerve pain are numbness, tingling, or weakness. I like to think of this as sciatic pain, radicular pain. And then it's important to differentiate between acute pain and chronic pain. Acute pain is pain that comes on quickly. It can be severe, but lasts a relatively short amount of time. And then chronic pain is pain that lasts longer than 12 weeks despite medication or treatment. I like to include the definition of total pain because this can be present at any point in somebody's life, but often presents when people have chronic conditions on top of a newly diagnosed condition. So total pain is associated with the early work of Cicely Saunders, and she did research about articulating the relationship between physical and mental suffering. Total pain includes physical symptoms, mental distress, social problems, and emotional difficulties. And as I know, it's hard to treat with medication alone. It's helpful to have an interdisciplinary team approach to treating pain. So the meat and potatoes of managing pain symptoms in older adults and some key considerations for treating older adult patients. It's important to assess the underlying cause and type of pain and acknowledge that chronic pain is common among the elderly population and often results from the normal aging process or from chronic conditions that have been present for decades in somebody's life. The aging process is not uniform. Chronological age fails to address the heterogeneity among the elderly and therefore necessitates individualization of regimens. So not everybody ages the same way, and there's various lifestyle, genetic determinants that can impact how people age. The functional status of the patient and the patient's ability to perform daily activities must be evaluated to determine the degree of independence, level of need for caregivers, as well as overall quality of life. Again, this highlights the fact that as we age, we tend to need more people involved in care unless you're able to maintain independence. When prescribing medications, it's also important to involve caregivers, write down medications or review medications frequently with the patient and the caregivers. And it's important to know what other medications, supplements, herbals the older patient is taking to account for polypharmacy and or drug-drug interaction. So avoid medications that work on similar pathways or potentiate similar side effects. And most older patients are on more than one medication, at least in the United States. And around the world, heart disease, diabetes is on the rise, and there's a lot of medications that are prescribed to treat those chronic conditions. So when considering pain medications, it's important to think about what other medications or supplements your patient is taking. Some more considerations for older adult patients in managing pain symptoms: non-drug and topical agents for nearly every older patient would be preferred due to their excellent safety profile. Non-opioid analgesics should be considered for all older patients with pain that limits function. So anything that's limiting mobility, sleep, or ability to perform activities of daily life, that's what ADL stands for. And adjuvant analgesics for patients with neuropathic syndromes. So the theme of this slide is consider non-pharmacological interventions or topicals, as they're considered very safe with a low side effect profile for older patients. Other non-pharmacological interventions to consider: weight loss. Can improve mobility, decrease pressure on joints, and contribute to an enhanced sense of emotional enjoyment. Exercise. Last week in my presentation, we discussed the benefits of gentle exercise in terms of relieving insomnia, maintaining mobility and functionality. It can also help with pain management. occupational and physical therapy if you have access, or if the patient has access to occupational and physical therapy. It can help with mobilization, strengthen muscles that are compensating for weak areas of weakness. And then also consider the use of assistive devices. So if patients experiencing pain in a joint, it might be helpful to have them evaluated for a cane or a walker to help reduce pressure or stress on the joint that's being affected. Again, circling back to topical therapies or analgesics, topical NSAIDs, non-steroidal anti-inflammatories, are an important alternative to oral NSAIDs in the elderly because of the decreased systemic side effects and very few cutaneous effects like rash or itchiness at the site of application. So if somebody has chronic pain, joint pain due to natural aging of the musculoskeletal system, it might be helpful to consider prescribing or using topical NSAIDs for knee and osteoarthritis pain. And then a good key to prescribing in older patients and any patients when you're thinking about pain medication is to start low and go slow. So even with topicals, you want to see if you can get the longest duration with the lowest dose. So in continuing this theme of non-opioid analgesics, I wanted to review some medications that you may have access to and utilize in your practice. So acetaminophen or Tylenol comes in various dosages. Again, start low and go slow. Tends to be pretty affordable in the oral form. We do have it available in the IV form, but that's only when patients are hospitalized, and there is some availability as a suppository and a liquid. So the benefit of Tylenol is it does have a lot of routes of administration available. You do want to monitor liver function with prolonged use, and there is a risk of hepatic toxicity if more than 4 grams is used per day. So you really want to make sure that instructions are given to your patient that you want not to use more than 4 grams per day, and to monitor liver function if patients are using it consistently around the clock. Non-steroidal anti-inflammatories and non-steroidal anti-inflammatory drugs are often used for bone pain or fascial injury. There is an increased risk of gastrointestinal ulcers, bleeding, and you want to monitor for nephrotoxicity. There are some medications such as naproxen and aspirin that have less of a CV risk. However, you really want to be cautious in elderly, especially due to the risk of ulcers and bleeding, and make sure that your patient isn't on an anticoagulant or steroids if prescribing NSAIDs, or if the patient is using NSAIDs. That's why topical NSAIDs are preferred over oral in the elderly population. Ketorolac and diclofenac. Ketorolac is used in the IV form, inpatient. Rarely do we use it in the PO form. Outpatient, and diclofenac as well. There's an increased risk of GI bleeding, more so than NSAIDs, associated with these 2 medications. And there's limited use, recommended only max of 5 days for ketorolac, and discontinue after 5 days due to that increased GI bleeding risk. Ibuprofen, again, there's a maximum daily dose of 2,400 milligrams, and it should be divided throughout the day between every 4 to 8 hours. It does have the lowest risk of GI complications and hepatotoxicity, and that's at doses of 1,500 milligrams per day or less. Saloxib is also, and medication that's available and has minimal to no inhibition of platelet function, and avoid if there's an allergy to Bactrim. Gabapentin and Lyrica or pregabalin are used to treat neuropathic pain, and there's multiple off-label uses for both of them. So I think if you were present last week, I talked a lot about using one medication for multiple symptoms. Gabapentin and Lyrica are two medications that are utilized for more than just neuropathic pain. The recommendation is to start low again and go slow and assess tolerance. So you can see the dosage guidelines on this slide. And then just of note, if a patient does have impaired renal function, you don't want to stop abruptly. You just want to dose reduce and assess for any side effects or adverse effects. Duloxetine, venlafaxine, they're SNRIs, which also are used to treat neuropathic pain and then also have other symptoms that they can treat. Venlafaxine can treat anxiety and menopause-like symptoms. Cymbalta, duloxetine can help with anxiety and is often utilized with gabapentin to help potentiate the effect of treatment of neuropathic pain. Starting dosage recommendations are noted in this slide. And then also for duloxetine, you want to be cautious with renal impairment and avoid if the creatinine clearance is less than 30 or if there's end-stage renal disease. You also want to be careful with duloxetine due to risk of bleeding, especially if co-prescribed with an NSAID. And then venlafaxine, there's a max dose recommended, as you can see there, and also caution with impaired renal function and a dose reduction recommended for hepatic impairment. Baclofen is a skeletal muscle relaxant. I actually tend to avoid this in older patients just because it can cause sedation, sleepiness. And my experience, I haven't seen as much benefit from baclofen in treating the different types of pain. However, it is an option and does have multiple off-label uses, such as treating hiccups and spasticity. You do have to taper and you do have to dose reduce if there's renal impairment and avoid if there is end-stage renal disease. Also caution if there is an underlying mental illness diagnosis. Tizanidine, cyclobenzaprine are both medications used to treat muscle spasms, and the recommended dosing is on the slide. Caution with tizanidine, dose reduce with impaired creatinine clearance. And then cyclobenzaprine, you can utilize and no adjustment for renal dosing. You just want to be cautious if utilizing with other anticholinergics, which we tend to try to avoid in elderly patients due to risk of serotonin syndrome. Steroids, dexamethasone are helpful, is an anti-inflammatory. You do want to avoid prescribing or having your patient take them in the evening, the afternoon. It can contribute to hyperactivity. It is one of those medications that you can use to treat multiple symptoms, for example, nausea, vomiting, fatigue, bone pain. And then you do want to continually assess response. In some elderly patients, there is this hyperactivity that persists, and some people don't tolerate it. Loratadine, we usually prescribe when there's bone pain that's related to Neupogen injections. There's limited evidence, but a lot of anecdotal evidence. So I just included it there if you have patients with severe bone pain receiving GCSF medications. The big caution is treating pain in older adults with opioids. So oftentimes in patients who have cancer and cancer pain, opioids are recommended. And it's important to weigh the risk benefit of any medication, but especially opioids in older adults. I'm just going to discuss medications that are commonly available and utilized by most prescribers in the United States to treat cancer pain or to treat pain. There are some other medications available, but they require more specialist training. I'm thinking about Suboxone, naloxone. So we'll stick with traditional opioids. Morphine, generally available throughout the world. Most common pain medication used to treat visceral somatic pain, multiple routes of administration, so we can utilize it orally, IV, and it has a duration of action of 3 to 7 hours, which is important to think about, not only with morphine, but with all opioids when prescribing to elderly patients. Again, clearance of opioids, clearance of any medications can be prolonged or delayed. And so these duration of action hours may be longer in older patients. The half-life may be prolonged depending upon kidney impairment or liver impairment. Specifically, morphine is not recommended in renal failure. However, if morphine is the only medication that you have available, start low with dosing and go slow. You really want to assess patients' response to morphine administration and wait for them to start to experience some pain before prescribing another dose, so you get a sense of what the half-life or duration of action is for that specific patient. Again, it's not a contraindication if this is the only opioid available to treat pain. You just have to be cautious with renal impairment and even with liver impairment. Oxycodone, also used to treat visceral somatic pain, available in an oral form. You can see the duration of action, the half-life. Again, caution in older patients, these may be prolonged. There is a high abuse potential, and this medication in the United States has been associated with the opioid epidemic that we're currently dealing with. It doesn't mean that we avoid prescribing it. It just means that we utilize opioid use or misuse tools to further assess people's risk of addiction or misuse. Hydromorphone, also used to treat visceral somatic pain. It's convenient because it's we can prescribe it in oral, IV form. Again, note the duration of action, the half-life. You can use cautiously in renal failure. It's not contraindicated, and often we do utilize hydromorphone or Dilaudid in patients who do have elevated creatinine because of the multiple modalities of the multiple routes of administration. It is preferred over morphine. So if I only had access to hydromorphone or morphine in somebody with renal failure, I would choose hydromorphone. Again, thinking start low and go slow. I highlighted fentanyl and methadone or bolded them. These are the preferred opioids if available and safe to use in patients with renal failure. It may be a little bit surprising, but methadone is actually one of our most preferred medications to treat visceral, somatic, and neuropathic pain. It does have some cross coverage with neuropathic pain and goes back to thinking about getting the most bang for your buck with a medication. And so If you have access to methadone and if you feel comfortable prescribing it or have training prescribing it, it is effective in treating visceral, somatic, and neuropathic pain. It's available in oral and IV form. You do have to be careful, and that's why I use caution if you don't have experience or haven't had training. The half-life, as you can see, is variable anywhere from 15 to 190 hours. And the duration of action is also variable anywhere between 6 to 12 hours with the oral and the IV form. And so you do want to use caution in opioid naive patients, and it's usually prescribed by a specialist. But again, it's a very effective drug in treating multiple types of pain. Fentanyl is utilized often in our cancer population at Memorial Sloan Kettering. It's used to treat visceral and somatic pain. It's available in a transdermal patch application, which is helpful, especially in patients who aren't able to tolerate PO intake, or patients who have malignant bowel obstructions or any type of head and neck cancer and aren't able to tolerate PO and need a long acting or don't have good GI absorption. It is also available in an IV form and can be utilized in that way. Duration of action for the transdermal patch is 48 to 72 hours. And so there's variation in how long it can take to start absorbing. Generally, it's anywhere between 8 to 12 hours after the patch is placed that steady state is reached, and so the half-life is 13 to 22 hours. So if you take off the patch, you still have a significant amount of medication being delivered. It is safe in patients who have renal impairment. Again, caution in patients who are opioid naive. I would not prescribe a transdermal patch or methadone to patients who have never been exposed to an opioid or been prescribed an opioid, or who are not on a long-acting opioid already. I like to point out that there are some common side effects of opioids, and just if you are prescribing morphine, hydromorphone, oxycodone, fentanyl, methadone, all of them have the same side effects and are present in patients at any age. For elderly patients, constipation is something really to consider and treat. As we age, GI motility decreases, and so you really do want to make sure that you're prescribing laxatives. Nausea, vomiting can be a common side effect. It's not contraindicated to stop. You don't have to stop the opioid, but just treat it. Sedation, again, as patients age, the half-life creatinine clearance is prolonged, and so you don't want to be stacking medication. It can contribute to increased sedation in elderly patients. Delirium, difficult to separate sometimes in the older population. Infection can present as delirium, but delirium is also a side effect of opioids. Respiratory depression, always use caution. Again, if patients have delayed clearance, you want to make sure that you're not contributing to sedation and respiratory depression. Some pearls to take home of this talk is aging is an individual process. Not everyone ages the same way, and treatments need to be individualized. The elderly population is increasing exponentially, especially in developing countries. So this is a population that we really have to understand and treat accordingly, and take into consideration what their needs are when we are treating them. And the normal aging process impacts pain and pain management. Assess the type and cause of pain, and start low and go slow. These are the resources that I utilized, and Caitlin will be sharing additional resources that I wasn't able to embed in this presentation with you all as well. Thank you for your time. It's a pleasure to be back.
Thank you so much, Renee. That was wonderful. Really appreciate your time. And just as a reminder, if you have any questions for Renee, please add those to the Q&A tab at the bottom of your screen. And we'll be going over all of the questions at the end if there's time, or if not, we'll share them with the presenters offline. But thank you so much, Renee. And Vanessa, if you are ready, please feel free to share your screen.
Okay, great. Can you see that okay, Caitlin?
Yes, looks perfect.
And you can hear me okay?
Mm-hmm. Perfect.
Okay, great. Hi, everyone. It's a pleasure to be with you today from far away. And I am going to give an overview of pediatric pain management. I just want to acknowledge that a lot of this information is from the ELNEC consortium, the End of Life Nursing Education Consortium. I'm faculty on that project, and so I'm sharing a lot of the information that we teach there. So we have a lot of material to cover in a short time. I will do my best to get through all of it, and you will have the slides after, obviously, if you want to look at them more thoroughly or ask questions. So today we're going to talk about some of the barriers that exist in pediatrics to adequate pain relief. We're also going to talk about all the components of a thorough pain assessment. We will describe some pharmacologic and non-pharmacologic therapies that are used to treat pain in children. And Renee covered a lot of the medications and some of the things that are the same in pediatrics, which was great. So I don't have to repeat some of the basics on that, but I will tell you when some of the things are the same or different in pediatrics than they are in adults. We will also discuss the role of the nurse overall in pain assessment and management in pediatrics. So in this first part here, I want to talk about just pain overall. The definition of pain is very subjective, right? Pain is whatever a child says it is. So we know from being around different people of different ages that everyone will have a different reaction to pain. And someone might tell you that you know, their pain is very severe. They might be sitting very quietly, and someone may tell you that their pain is very mild and they physically look like they're in pain, right? So we have to just be careful as clinicians to not make our judgment about what appears to be pain or not pain. Certainly we're doing that as part of our assessment, which we'll talk about, but really when you ask somebody whether what their pain is, it's whatever they say it is. And this is especially true in children. Pain can be acute or chronic or a combination of both. And obviously it's influenced by many factors. And so because of that, when we think about treating pain, we want to use a multi-dimensional approach because there are a lot of factors involved in managing pain. So Renee gave a really nice overview of the types of pain. So I won't spend a lot of time here, but just be familiar with the fact that they are the same types of pain in pediatrics as they are in adults. It can be nociceptive pain or neuropathic pain or procedural pain, right? For children, it's often traumatic to have procedures done. And so that's a specific niche of pain management as well. Renee also talked a lot about the concept of total pain, which was great. She gave a really nice overview, and this applies in pediatrics as well. So again, the concept of total pain being a combination of physical pain, psychological pain, spiritual pain, and pain that's affecting the social aspects of their life. And I just want to note that when you recognize total pain, you want to be aware that it's very difficult to treat total pain. So when you become aware of this, that someone is experiencing all of these different components of pain, they're in it's a tough situation to try and to address this, right? We're pretty good as nurses and as clinicians in dealing with the physical pain. We never promise that we can get it to zero. We never promise anybody that we will totally get rid of all of your pain completely, because we don't always know that we can do that. But we are pretty good at trying to get the pain to be the better than it is now, or doing a pretty good job of at least getting it to some manageable level. But when you think about the spiritual aspects and the psychological aspects, those are a lot harder to treat, right? Oftentimes we see people that feel like they are really struggling with their faith. They are questioning why they got ill, or especially in pediatrics, why their child got ill. And, hopefully we'll have a few minutes to talk about some of these things, but it would be fascinating for me to learn more about in your culture what people's views are about this, right? I have worked with families where they felt like they were being punished if their child became very seriously ill. And so there are no right or wrong answers to any of these things, but it's just something that we need to think about. And it's part of what makes this pretty difficult to treat, because obviously we can help people work through some of those issues, but we don't have easy fixes for any of those things, right? If someone is really suffering on an existential level, that can be the work of a lifetime, and which is what can make this very complicated to treat. So just want to be aware that that very much exists in pediatrics as well. So what is really the scope of pain in pediatrics, or the experience? We know that pain affects children of all ages. I will touch upon the neonatal population just a little bit, because that could be a whole other topic. Any of these things could be a whole other topic that we could talk about for a while. But so I will touch on neonatal, but you just want to be aware that when I use the word children today, I mean children of all ages. So that could be, we do perinatal palliative care before a child's even born, helping the family think about decisions. And obviously we're not managing pain until after a child's born, but it can be from the time of birth all the way up through adolescence and young adulthood, which we often see children until about the age of 25 here in the United States. So I'm using the word children, but really mean the whole span there. And there may be healthy children who have some event or some experience that causes pain, or they may be living with a serious medical illness sometimes from the time of birth. So this is also very different than the adult world, where yes, of course, adults can be living with something for many years, but you may see a child who is born with some condition that causes pain, and their life may be very short, or it may be for many years. But obviously pain affects all areas of quality of life. And so that is also the same as it is in the adult population as well. And just want to also note that in pediatrics, we are often thinking about not only how pain is affecting the child, but how it is affecting their family and how their family functions, because it will take a serious illness, as I'm sure you know, takes a toll on everyone in the family. So just to briefly mention some of the barriers to providing adequate pain management or to pain relief, healthcare professionals themselves can be a barrier in the sense that they may not necessarily understand how to effectively treat pain in children, or they may be hesitant to do so if they don't know how to do it or don't feel prepared to do it, or have fears about, overdosing in a child, or are just not as comfortable doing this. So they can be a barrier also if they, don't have a good understanding of this. So it's necessary for us to teach this, right? Which is why it's great that we're together today. Healthcare systems, I'm sure this is very different where you are, also from where we are here, but it can certainly be a barrier. For us, it's things like insurance coverage and access to resources, and I'm sure that you have access issues as well in your country, but the whole system of care can really be a barrier to, are we able to get some of these medications? Do we have enough providers that are trained to do this? And patients themselves and families can also be a barrier. Cultural beliefs play a lot into this as well. If people are hesitant to be open to just managing pain in children, they may be afraid of using certain medications. Many people culturally feel like, you have to just sort of suffer and live through pain. And so these can be barriers. It doesn't mean that we can't overcome them, but they're just things to be aware of that can be a challenge for sure. So what are some of the myths related to pain and pain management in pediatrics? So meaning things that people think are true, but are not necessarily true. And one is about respiratory depression. Certainly, we can cause respiratory depression in using certain medications to treat pain, but when this is done properly and effectively, it should not cause someone to stop breathing. But that is a fear or a myth that people think, okay, if we start an opioid, then they're going to stop breathing. It could happen, but again, if it's done appropriately and properly, that should not be something that occurs regularly. Substance use disorder or addiction. This is very common that people think, oh, if we start that, in a young child, are we going to become addicted to it? And again, if this is done properly, addiction should also not be an issue in pediatrics. People sometimes think that if a child's playing or sleeping, that they do not have pain. Oh, they appear to be fine. Look, they're playing with the other kids. They're taking a nap. They must not be in pain. And we know that this is not true. Children are very resilient and adults are as well, but children will often carry on, and sometimes playing or sleeping is a distraction from pain. And so just because someone's sleeping or actively engaged in something doesn't mean that they're not having pain. It's also a myth that pain necessarily indicates a worsening of disease or approaching death. That's not always the case. Someone may be having more pain, but it doesn't necessarily mean that their condition overall is getting worse. So what are some of the facts now about childhood pain, even though we just talked about some of the myths? And I see that some of you are raising your hands and putting things in the chat, and we'll hopefully get to some of the questions at the end, but I'm going to keep going for now. But some of the facts about childhood pain, right? I just mentioned this, but opioid addictions are rare, very rare in pediatrics if this is done properly. We also know that repeated exposure to painful procedures leads to increased anxiety and perception of pain. This is very true in pediatrics. I can tell you that when I'm in clinic, if I reach into a certain cabinet above my head to get something like a cotton ball or a cotton swab or something out of the cabinet that I need, I can have a child on the exam table that starts screaming. And that's because they know that they think they're getting a shot. They think that if I'm getting something out of the cabinet, I'm going to do something that's painful to them. And so right away, often I try to get things out of the cabinet before the child's in the room, or I say, which kids might not always believe, you can't always convince them, no shots today, because I don't usually give shots in my clinic, but I'm not doing anything that's going to hurt you. But kids get used to that, right? They have a very good memory. And if especially someone living with a chronic illness, and they've had lots of painful procedures, they are going to have increased anxiety around that. We also know that children as young as 3 years of age can use pain scales to indicate where their pain is. And I'm going to show you some more of these scales as well as we start to talk about assessing pain. I told you I'd mentioned the neonatal piece a little bit. And so here is that information. These, again, are myths or things that people believe to be true that are not necessarily true, that neonates are incapable of feeling pain, that they have immature nervous systems, that they have incomplete myelinization, meaning that their nerves are not completely myelinated, and because of that, they can't feel pain. And we know that that's not true. Even though their nerves are not fully myelinized at birth, they can still perceive pain. People also think that neonates or very young children, infants, will not have a memory of pain, and we know that that's not true. And also that using analgesia or pain medications is unsafe in neonates. And again, that is not true. So what are some of the facts or the things that are true? We know that the perception of pain occurs very early in life. And I just gave you an example about perception of pain, that idea of getting something out of the cabinet. Often the fear or anxiety makes the pain worse, right? Pain is really what somebody is perceiving it to be. So they can certainly become more anxious or worked up about the pain just based on their thoughts about it. We know that neonates or infants exhibit physiologic and behavioral cues of pain. So there are things we can see physiologic, meaning like an elevated heart rate, an elevated respiration rate. We can see when neonates are experiencing pain in some instances. And again, we know here as well that there is no risk of addiction, although tolerance and physical dependence can occur, which I'm going to talk more about. But if dosed appropriately, there should not be the risk of addiction in very young children. So how does pain impact life, or what is it like for someone to be living with a child in pain? This can be very difficult for families. There is often a sense of helplessness that parents or guardians or whoever it is that's taking care of the child, they may feel very helpless that they can't really do anything to help their child or to get their pain under better control. They may feel unprepared or unknowledgeable, like they don't know enough about this, or they're not sure, what to do. It may feel horrible or frightening, right? Very scary to have a child in pain and feel like you're out of control and can't do anything about it. And sometimes you see that families may wish for relief, even if that means death. Obviously, no one wants their child to die, but in our experience with working with families, no one wants their child to be suffering either. So sometimes you see instances where the pain is so bad, where they, families feel like we just want this to be over. And if that means that we don't want them to suffer anymore. Okay. So what is in pediatrics, what is the pain experience? It can be from an acute onset or of illness, a trauma, something that occurs suddenly. So we very often see what we call a previously healthy child. They were doing fine. They had an accident. They, had a brain injury. They fell off their bike and, had an injury to their brain, or got some viral illness like a viral meningitis or something, where it can be acute or it can be a chronic medical condition. Often pain may be associated with hospitalization, being in the emergency room, which is what ER stands for, emergency room or emergency department. The PICU, which for us is the pediatric ICU or intensive care unit, a general admission to the hospital. And this can be challenging for pain management, right? It's going to be very different in managing pain acutely or when they're in the hospital, depending on what the condition is. So is it an acute accident or trauma where you're managing pain, or is it a longitudinal illness where you're managing pain over time? And then again, if it's a minor injury or accident or a common childhood illness, we know kids are always getting around germs and getting sick all the time, and that would be managing pain at home for something much less severe. So we're now going to move into talking a little bit about the assessment of pain in pediatric patients. It is multidimensional, meaning that we look at many different areas. We use lots of different assessment tools. I will go over the tools briefly because I realize you may or may not have some of these tools where you are, and then how we communicate that assessment once we have figured out that someone is having pain. So when I say a multidimensional assessment, we're talking about self-report or parent report. They're telling you what the pain is, right? So what's going on, you're figuring out, tell us what's happening. Tell me where it hurts. Tell me how long it's been going on. What is the intensity? How bad is the pain? Is it better now? Is it worse now than when it first started, right? What is the intensity? You always want to know that. What's the quality of the pain? Meaning, what is that like? When Renee went over the different types of pain, right? Is it shooting pain? Is it sharp pain? Is it dull pain? Is it aching? What's the pattern of the pain? Is the pain constant? Does it start and then stop? Is it only at bedtime? Is it only in the morning? Is it only when doing a certain activity? All of these things are important to know what the pattern is. What are the aggravating or the alleviating factors? So what are the things that have helped with the pain or made the pain worse? Someone may say, we put some ice on it and that helped, or we put heat on it and that helped, or it made it worse when they were up and active, or it felt worse when they were lying still in bed. So you want to know from a family when they're presenting to you with a child in pain, what are the things that they've tried, what's been done that's made this better or worse. You also want to get a very thorough medication history to figure out what medications they've used, what have they tried, what have they been on in the past. You know, if someone comes in and tells me we tried morphine previously in our child and with our child it didn't work, but hydromorphone worked instead, then I'm going to believe that and I'm going to go with what they're telling me worked. Obviously, you have to use the medications that are most appropriate, but you want to get a really good history on what they've given now for the pain or what they perhaps have used in the past if this is a recurring illness. You also want to be sure to ask about the impact on quality of life. How is the pain affecting the rest of their life? They can't play with their friends. They can't go to school. They can't, eat a meal with their family. They can't interact with other people. They're not talking anymore. They're not sleeping. They're not eating. What's going on, right? So you want to figure out how is this affecting the rest of their life. The types of assessment, again, self-report or report from the family, depending on the age or the ability of the child to tell you about their pain. You want to find out from that report. Also behaviorally, right? Observing what's going on for that child. How are they acting? If it's the first time you're meeting that child, you want to find out if this is their normal behavior or is this different. You're relying on the people who know them best and spend time around them. And that could be a nurse if they're the person who spends a lot of time around the child. You want to find out from them what's going on. And physiologic changes, as I mentioned before, things like heart rate, respiration rate, what's going on in their body. Is the blood pressure changing? Do they have a fever? What are some of the signs and symptoms we're looking for that someone is experiencing pain? Proxy report is also, again, a caregiver telling you or someone who spends a lot of time with that child telling you what's going on in addition to the child themselves. And then there is also the use of scales, which I'm going to go through a little bit now as well. So it's very important when you are managing pain that you always reassess pain, because what's important is to know the change in pain. Right? If I meet a family for the first time and that child's in pain and I prescribe or start some intervention, I either prescribe it myself or I'm the one giving the medication or doing some intervention around that pain, I want to know, did it get better or worse? Right? If someone's in the hospital, their child is hospitalized and I go down to the floor where they are and I say, okay, let's try this. Let's try giving some, ibuprofen at this dose. And then I never go back and see if that worked. How am I going to know if it made any difference? Right? So you always want to do an intervention and then check back and see, was there a change in pain? Is there a change in the analgesic regimen, in the medications that are being used? Does there need to be a change? Has there been one? You want to assess this consistently and again in appropriate time intervals after the intervention. So if I give a medication, for example, that I know will take 20 to 30 minutes to work, then I need to go back in 20 or 30 minutes to find out or call somebody on that unit and say, did that work? Or check in with the family at home if you're practicing in the community, but you want to have some way to get a report of whether or not it worked. The use of diaries can also be very helpful for families to record pain over time, because they have lots of things going on and then they're trying to tell you about the child's pain and they can't exactly remember when it started, when maybe it was worse last night, maybe it was the night before, I can't quite remember. So giving, having a space where they can write this down or record it somehow. If they can't write it down, can they somehow keep some sort of record of the pain that their child's having so we can look at patterns. These are some of the assessment tools. I'm not going to spend a lot of time on this because I realize you may or may not have access to the use of some of these tools. There are many, many, many tools available, and we don't necessarily use all of them in our system here. We use some of them. Some are more common than others, but I want you to just be sort of aware of them. The CRIES scale is something that we use quite often in neonatal populations, and CRIES stands for something where you're looking at certain behavioral cues, because obviously in a neonate, in an infant, they can't tell you because they can't speak, right? So we're observing behaviors of pain, and then you would give them a score. The premature infant pain profile would be for premature infants, obviously. The neonatal infant pain scale and the neonatal pain agitation and sedation scale are all scales that are available specifically for the neonatal and infant population. Many of these can be found online. I'm not sure how it works there, but for us, it has to be the tool that our institution uses. So we usually have certain tools that we use for different ages. In pre-verbal or non-verbal children, so either they can't speak yet or they can't speak at all given their medical condition, the FLAC is the scale that we very often use, and that's again observing behavior because they're not able to tell you. There's a pain observation scale, a modified objective pain score, and then a non-communicating children's pain checklist. Again, this is just an overview of some of the scales that exist. There are self-report pain intensity scales for children who are able to self-report. The FACES pain scale is one you've probably seen. There's no words on this, so this is kind of a universal scale that's used in most countries where it just has the faces with worse pain, right? It starts with a child smiling and then becomes a little bit less of a smile into a frown and then someone who's crying, right? And a child would point to where they are on that scale. The Oucher is another pain scale, the visual analog scale, and a verbal report scale, but I'd say the FACES scale is the most commonly used one here. So again, some of the things you'll do for overall pain assessment, you want to do a brief pain inventory, you want to use some tool to look at a quality of life. There is also pain scale specific for neuropathic pain or if someone's experiencing neuropathy, and there are also some adolescent specific tools as well. Once you've assessed that someone is in pain, you want to be able to document that clearly somewhere, whether that's in the patient's chart, whether that's in a note, if you're doing this out in the community, wherever you document the information from your visit, you want to clearly document your assessment, what was the intervention you did, and what's the reassessment of that pain, right? Gave some acetaminophen, child reported, child fell down and reported having pain in their knee where they scraped it. We gave them some acetaminophen. It checked back 20 minutes later to see whether it was working or not. That would be a very simple example of what did you first see? What was your intervention? And then how do you reassess? And then you want to come up with a care plan for pain so that you're never leaving them with unsure of what to do. You want to say, this is what we're going to do. If the pain gets worse, you may try this. If the pain, stays the same, you can continue giving this for how long, etc. So I'm going to talk next about pharmacologic therapies. I realize I'm moving quite quickly here, but it's a lot of information to cover in a short time. So again, some of this I won't repeat if Renee already covered it in her section, but we want to just talk a little bit here about the different medications that we may use. So the pharmacologic therapies available. And these are some of the things that I'm going to touch upon. So severe pain we know is a medical emergency. If someone is experiencing absolutely severe pain, we treat that as an emergency. Rapid assessment and treatment is imperative if someone's having severe pain. And we want to provide an interprofessional care plan, which includes the family. So again, thinking about our example of total pain, who do we need to try and be in that plan to manage the pain? Do we need a social worker? Do we need a chaplain, depending on what's going on? The WHO is the World Health Organization. Some of you may be familiar with this. They have a two-step analgesic step ladder, which you may or may not have seen before. It used to be 3 steps. We now really think of it as 2 steps, but we want to start with the appropriate medication of a specific strength based on what the severity of the pain is. So if they're having mild pain, we would probably provide a non-opioid analgesia such as acetaminophen or a non-steroidal anti-inflammatory drug, which is what NSAID stands for, and NSAID, and that's something like ibuprofen. If they're having moderate to severe pain, they may be started on some combination of acetaminophen or an NSAID with an opioid, or they may just be started on an opioid. So it depends on how severe their pain is. So a little bit about some of these classes of medications or specific medications. Acetaminophen, which we call Tylenol. Acetaminophen is the generic name. that it goes by. It's useful for mild pain. It can have anti-inflammatory action, and it works synergistically with morphine. So if you're giving somebody that and an opioid, you want to be careful knowing that they're both going to have an additive effect. Non-steroidal anti-inflammatories can be used in mild, moderate, acute, or chronic pain alone, or they can be used in severe pain in combination with an opioid or another medication. They can also be very useful in the treatment of bone pain, but you want to be careful in using them if someone has something where they may bleed or you're worried about bleeding. So we don't give these post-operatively. We don't give these in someone if we're worried about them having a bleed somewhere or a gastrointestinal bleed or something like that. Okay, so here we are, the side effects that come with some of these medications with non-steroidal anti-inflammatory drugs. There can be gastric irritation, heartburn, ulceration, or bleeding. So that's why we're cautious. You want to use some other medications, a gastroprotective medication, if you're prescribing these prolonged over time. They can also have an effect on platelet aggregation, hence the bleeding. And renal effects are rare, but in a child who has renal insufficiency or nephrotoxicity, or those are things that can occur with prolonged high doses. So if a child has renal insufficiency or some other renal disease, you want to be very careful with using this class of medications and dose appropriately. You would change the dose. Combination products, I'm not going to spend a lot of time here. We try to avoid these in pediatrics. They can be used very commonly in adult populations, but these are medications that have more than one medication. So an example would be hydrocodone, which is acetaminophen, and some other medication and hydrocodone together. So something like Vicodin. Percocet, again, used in adults, would be oxycodone and acetaminophen. We don't use these in children because we are concerned that they will get too much acetaminophen. You have to really watch the level for giving acetaminophen. And so if you're constantly giving this throughout the day and over time, are we hitting too high on the acetaminophen level? So we try to not use these drugs in children. There also may be the concern that it masks a fever if there's a fever that occurs because they're getting that much of the acetaminophen. And then if you do need to use acetaminophen alone for something like mild pain or a fever, you can't use that if you're already giving it in your combination medication. So for these reasons, we don't often use these in pediatrics. When we talk about opioids, which I know Renee covered a lot of this as well, morphine is the gold standard. It's pretty inexpensive, and out of all of the opioids, there's a variety of routes in which you can give this in different formulations. We know a lot about it, and it's useful for moderate or severe pain. Fentanyl is often used in anesthesia or procedural sedations. It can be used for severe pain. The patches are sometimes helpful in chronic non-malignant pain or in cancer, but usually this has a pretty quick onset and a very short half-life, so it doesn't last as long for fentanyl. I'm giving a very broad overview here. Hydromorphone is more potent than morphine, meaning it has a higher concentration for that medication when you're prescribing. It can be used instead of morphine or something like oxycodone. You want to try not to give two opioids together. So you would use one or the other depending on that particular child's pain. Methadone is used in chronic and neuropathic pain. It has a very long half-life and takes a longer time to get to a steady state. And we usually make dose adjustments when we're starting this after a couple of days because we need to see how it's going to work. It can take up to 48 to 72 hours to really have full effect and see, how all of the repeated doses have had an effect on the pain. So we usually go slow when we're going up on this to start. Again, a little bit about the neonatal population. We just want to be mindful that they have reduced clearance for the majority of opioids given their body systems. And so you want to be very careful in prescribing these, that you make sure the dosing is appropriate. Some medications can have a prolonged half-life or also accumulate in the system. So there is specific prescribing techniques for prescribing those who work specifically with the neonatal population. There are also other medications that we use called adjuvants or co-analgesia, medications used in combination with an opioid to either enhance the effect of the opioid or treat a specific type of pain. And these are just some examples of ones that we use. Neuropathic adjuvants can be something like an anticonvulsant or an antidepressant. There's also lots of side effects from pain medication, as I'm sure you know. Constipation is always one, so prevention is key. We always want to start somebody on something for constipation when we start them on an opioid medication. So automatically we would give them something, and there's some medications listed there. Sedation is also a possible side effect, and parents are often worried about this in children, but usually there's tolerance within a few days. You obviously want to watch for this and make sure that someone isn't completely wiped out, but know that, explain to families that normally once the children habituate and get used to having that medication on board, they tend to be less sleepy. But again, you want to monitor for that, and if they're not getting used to it, and then you want to think about changing that or changing the dose. Urinary retention can also be a side effect, and we often give a medication for that. Nausea and vomiting, we would prescribe something for that as well. And pruritus or itchiness, right? We often use diphenhydramine, which is Benadryl here, hydroxyzine sometimes low dose naloxone, but not always. That's often after surgery. But just be aware of, these are all side effects that can occur, but you don't want to necessarily have to give 5 more medications to manage the side effects. So if any of these become intolerable, you may think about changing to a different medication to avoid some of these side effects. We talked a lot about this already, but just to be aware of some of the risks. That tolerance is that someone needs more and more of the medication to have the same effect. So you have to give higher doses, which is often okay, but you want to be careful if things like, renal disease or other things, that you're not just giving more and more medication if their system can't handle it. And physiological dependence would be their body not the same as addiction, but their body being used to that medication. And so that's why we never want to stop things abruptly, because they will have symptoms of withdrawals. So you want to taper down if you're taking somebody off. Respiratory suppression, I already talked about. It's exceedingly rare, but we want to watch for this. So I'm going to move through that. And then in procedural pain, you may use something topically or sedation for the procedure as well. So we just have a few minutes left here. I want to talk about titrating pain medication. You want to do a very thorough pain assessment, as I mentioned, providing a PRN dose or an as needed dose of medication. If you're giving it by IV or intravenous, or SC is subcutaneously, you want to reassess it in 15 minutes and in 30 minutes if you're giving it by mouth. If they're not having any relief, you would give another dose. And you want to keep doing this until you hit a spot where pain is relieved. So if someone's in hospital and you're giving continuous medication by IV, you're going to be looking at the rate and how much medication they're using over time. If you're doing this for medications that are being given intermittently, either by IV or by mouth, you want to give a dose, see how it works, give another dose, see how it works, and see how much medication you need to get the pain under control. And then you would calculate the dose as needed. So the PCA means a patient controlled analgesia, a button that they're pushing to get more medication, or you would not want to notify a provider if they constantly need more pain medication and you need to change the dose that they're getting. So I'm not going to go specifically into prescribing here, but you just want to think about the concept of how you go up. You don't start somebody at a really high dose. We always say start low and go slow and give a little bit more to see how much you need to actively get that child's pain under control. Same thing when you're coming down, as I just mentioned, you want to avoid withdrawals. So usually if a child has been on a routine dose of a medication for more than a week, 5 to 7 days, you may want to make a schedule for them to wean down off that medication. And many times we will contact a pharmacist to help us with that, depending on how complicated it is. You want to be very clear with the family if they're doing this at home and give them a calendar to make them easy for them to follow. And again, how long it takes to wean off something will often depend on how long they've been on it and how much of the medication they're getting. You want to be careful to monitor for the return of pain or any signs and symptoms of withdrawal, which are listed here when you're tapering somebody down off that medication. Just to touch on opioid rotation, I'm not going to teach you how to do the equal analgesia with the actual medications, the math, but you just want to think about if you're changing from one opioid to another. You may be doing that if pain is not well managed, despite giving more and more of it. Or, as I mentioned earlier, if the side effects are totally intolerable, you may think about changing to another medication. Equal analgesia just means giving a different medication in a dose that's equal to control that pain. So you must think about that when you're changing medications, because each medication has a different potency. So you're not giving 30 milligrams of morphine and then 30 milligrams of hydromorphone. You would have to do a calculation to figure out how much hydromorphone you would need, for example, to match the dose that they were getting of morphine. So, this can be failing to consider that, or failing to think about equal doses of pain medications when you're switching them is often the reason why people either have inconsistent pain control or become overly sedated because we didn't give the right amount when we change them over. So when you do this, you would calculate the total amount of medication that someone got in the last 24 hours and then convert to the new medication. Just touch on that there. There is a chart for you if you'd like to refer to that later for the different doses of the different medications. So this is our last section here in the last few minutes. How do we manage pain? We do dosing around the clock. They're given on a schedule. We don't want to give one dose and then wait and see if they're in pain again. We usually give them a schedule so that you try and get ahead of the pain and that you keep stable levels of that medication in the blood. And you always want to give them something for breakthrough pain if they have pain on top of that as well. Stay ahead of the pain. It's an individualized plan. Frequently assess it. And, if you end up in crisis, you're going to rapidly titrate to get to comfort, but you always want to have a plan in place for when pain escalates or if it escalates. How do we give medications in children? We often go the least invasive route. No one wants to get a shot or a needle, right? Think about their age, their developmental level. It can be, traumatic to be giving a child medication rectally or giving them a shot. So you want to use the least invasive route as possible and use your whole team. We have child life specialists, social workers, people who might work with the child to try and help them get through the pain. So giving it by mouth, transdermally is a great way in kids if you could put a patch on them if that's appropriate. Topically, again, IV or subcutaneously, these are just some different ways that you can give medications. And then to end up here with thinking about our non-pharmacologic pain management, depending what you have available to you, but just the presence of a caregiver that they're familiar with can be very soothing. Thinking about things like guided imagery or visualization for kids, deep breathing techniques, massage, hot or cold, positioning, physical therapy, medications we've obviously talked about, meditation, mentally relaxing, play therapy, very effective in children, Reiki if you have that available to you, hypnosis we often use in children, aromatherapy, which is the use of essential oils to alter someone's perception of pain, music, or hydrotherapy if you have that available. So lots and lots and lots of these. We could talk for, a whole other hour about different types of non-pharmacologic management, but you want to be familiar with what you have available to you in the community where you're working and try and use some of these things along with medications. We would never say use these instead of. You want to think about coming up with a plan that involves them. Again, for neonates or infants, you're thinking about, modifying the environment, minimizing sleep interruptions. We sometimes use oral sucrose, swaddling, infant massage, or music. And then when we think about pain at the end of life, this would be very different, right? How do we dose the opioids? Thinking about things like renal function and accumulation of metabolites and practical treatments that can be done at home if that's where the child will experience the end of life. We know the bottom line here is that we know that children who are dying of cancer, this is specifically that 47% of them, so about half of them, experience a lot of pain, and that being in pain at the end of life can hasten death. So we know that children are experiencing pain and we need to do a better job of this. And you also want to think about suffering, again, that we talked about, and what role does spirituality or religion play there. pain versus suffering, right? Actual physical pain versus existential distress. We talked about, and irretractable pain would be pain that's really difficult to get under control. And these are some things we might think about, something like palliative chemotherapy to keep them comfortable if they have cancer, radiation therapy, perhaps doing a nerve block, or a different kind of infusion. So this is another topic, but really there are other options when someone has pain that's really difficult to control. So just ending here with what the role of the nurse is in all of this, right? We're always advocating for the child and the family to make sure that they're getting the best management of pain that they possibly can. You want to be competent in doing this and doing it well, and knowing how to effectively manage pain and just being aware of it, right? Recognizing things like, oh, the child appears comfortable, so they must not be having pain, but really just being aware of what's going on. So in summary, we know that pain can be very serious in children. It must be assessed and managed consistently. It involves management from the entire team. And some of our golden rules that we think about, right, in pediatrics, if it would hurt you, it hurts them, right? So they say, oh, well, their kid, or a child who can't move very well or can't speak, if you're doing something that's painful, they're still going to feel pain, right? You want to approach children with the same respect you would an adult, and take them seriously, and that you have to build trust and cooperation with children as you attempt to manage their pain as well. So I will stop there. And I think we're just about at time. So thank you so much.
Thank you so much, Dr. Battista. That was excellent. Thank you for and so much material. So we're really thankful for that. Thank you. So it looks like we have about 2 questions in the Q&A, but if anyone else has any that they would like to add, I know there's a couple of hands raised. Unfortunately, we can't unmute you, so please try and add those questions to the Q&A if possible. We have a few minutes to address those. So I will go ahead and read out the first question that we've received, which is for you, Renee. It is, they want to know if it is advisable to add adjuvants to like lactulose and antihistamines to opioids to reduce opioid side effects routinely.
Hi, that's a great question. So both Venessa and I reviewed the side effects of opioids, and constipation is a known side effect that you do not develop tolerance to when you're taking opioids. And so, yes, when you are prescribing opioids to any patient, you want to prescribe a laxative. Lactulose is a laxative. It's not the medication that I utilize as first line. That being said, if that's what's available to you, use it. It will help produce laxation. It's important to understand the differences between what the medications do. Senna, which is an oral tablet, and Miralax, which is a powder that you mix in water, are the 2 medications that I mostly prescribe. Again, I start low and go slow. I usually prescribe Senna 2 tablets at bedtime, and Miralax powder. It's about it's a like a spoonful. You mix it in water once a day. You don't want to swing somebody into diarrhea because that can cause other complications. And so this fine balance of constipation, laxation, diarrhea is something that you will have to titrate over time. So, but yes, lactulose can be used. In terms of antihistamines, if somebody's experiencing itchiness as a side effect of the pain medication, if it's available to you, oftentimes I will try to rotate or treat, as Venessa said, with an antihistamine or some type of other medication that can address the pruritus from opioids if it's available to you. But definitely important to address the side effects of opioids, especially in the cancer population, because generally we will be prescribing opioids for cancer pain.
Thank you. Thank you very much. So Vanessa, our next question is just clarifying the upper age limit of pediatrics in this context as it differs from region to region. They're wondering if they heard 25 years in the US.
Well, it really depends. Things, unfortunately, for us in the US are often determined by insurance and what somebody will cover. So there is more and more of a limitation now in pediatrics of how old we can see someone, because they need to be seen by adult providers. So generally by licensure, for example, I'm a pediatric nurse practitioner. I am licensed to see children up through the age of 25, which isn't really a child, but I can prescribe and see somebody in my practice up to the age of 25. There are some exceptions when it's someone with a chronic illness who we've been seeing for 25 years and now they're turning 26 or 27, I might still be able to see them. But overall, there is a push to start moving adolescents to adult care at the age of 18. So between 18 and 21 to really what we call transitioning care to the adult population. So by licensure, I can see up to 25. Our hospital systems are really cracking down more now on moving kids out at 18. But this is two brief things I'll say about that, right? Children are living longer now with many chronic illnesses than they were before. So we are now having patients that are older than me, right? Sometimes in pediatrics, we may see someone who's been living with cardiac disease they were born with, who's living into their 40s and 50s. And so because of advances in medical technology, which is wonderful, people are living longer, but that means we need to get them to adult care. The other thing is that there's a huge movement now on transitioning care and trying to have this be a process that the recommendation is really that it starts at the age of 12, so that you're preparing somebody for that transition to adult care and not just saying, oh, okay, you're 18, you've been living with this disease for many years and you're used to pediatric care and now goodbye, you go to adult care. We try to prepare them for that and move them over. But so usually I'd say it's somewhere between 18 and 25, depending on where you practice.
Thank you so much. Okay, for this next question, I'll apologize ahead of time that I'm not well versed in drug names, so I apologize if I asked this incorrectly. But when using pain medication like corticosteroid or dexamethasone, is there a need to use a PPI or proton pump inhibitor like omeprazole? And whoever wants to take that one.
Yes, yes, definitely. You do need to use it because there is increased risk of bleeding. So you do need to use a medication that helps protect the lining of the stomach. And those medications are appropriate for using when prescribing corticosteroids. You did a great job, Caitlin, saying that.
Thank you. Great, thank you so much. The next question is, which medication is best for patients with abdominal pain secondary to hepatic metastasis?
I would say it depends. There's no one size fits all for these. So it really depends on what's going on for that particular patient. If they have, say that again, it was hepatic, they have underlying hepatic disease. Okay.
It says for patients with abdominal pain secondary to hepatic metastasis.
Yeah, so they have metastases to their liver and they're having abdominal pain. So, it really depends on, Renee just mentioned, right? If you've got them on is the abdominal pain visceral pain to an organ? Is the abdominal pain something that's like nausea and vomiting and we're giving something to manage that? If it's visceral pain to that organ, you're probably going to put them on some sort of opioid, but which one depends on how severe the pain is, what they've tried in the past, what else they're taking. Is the medication cleared through the liver, through the kidney? So there is no one stock answer for that. But I would say if it's visceral abdominal pain, meaning actually pain to the organs, like their abdominal organs, it would probably be an opioid. If it's pain that's like nausea, vomiting, constipation, those kind of things, you're going to give a medication specific to treat that specific symptom. I don't know what you want to add to that, Renee.
I just want to say that if we're opioids, definitely if it's visceral pain. And I love, Venessa, how you incorporated non-pharmacological approaches, especially with our anesthesia pain colleagues. Sometimes we'll utilize a block if it's like hepatic stretch that's contributing to the pain. But to Vanessa's point, you really have to assess what the underlying cause and type of pain is, and then treat appropriately either with an intervention or a medication.
Great, thank you. The next question I think is directed mostly at pediatric patients. They're asking what the role of using steroids such as dexamethasone in management of pain, especially in patients with CNS malignancy, and is it a good choice for pediatric patients?
Yes, so dexamethasone or a steroid is always a great choice for pain management. I guess we never say always, right? But in most instances, giving a steroid, dexamethasone, is going to be a really good choice for someone having pain. And if they're having central nervous system disease, yes, we often give them, and we're giving them pretty high doses, right? So you would start somebody at, high dose of steroid and then wean them down if you're trying to get acute pain under control. The thing there that you want to be careful with, of course, is that we know that steroids cause lots of lovely side effects, right? And so if you're going to be, if you're in this for the long haul, it's very different, right? I do palliative care, so I'm often thinking of somebody at the end of life. I may use high doses of steroids a lot more liberally if I know that I have weeks left, right? Perhaps, or days left, versus someone who has recurrent disease that they're going to be living with for months or years. I would still use a steroid, but I might use much shorter doses of it, like a burst dose, to get them out of acute pain, because you can't necessarily keep somebody on high dose steroids for a very long period of time, because you're going to have lots of other side effects from that, right? And so yes, they're a great choice and we use them a lot, but we often see where we'll prescribe like a steroid burst, we'll call it, or you would do this for 3 or 4 days if somebody's like in pain crisis, if it's more of a chronic illness.
Great. Excellent, thank you. And then we have one more question in the Q&A, which is great for timing. Let's see, so first of all, they say great presentation, thank you. And the second presenter, are weak opioids such as dihydroxidine and pentacosine recommended in children?
That's a very specific, we don't use them as commonly in children. Would I say that I've never used them? No, but it's not our first line. So, we kind of have our standard medications we use. If something else isn't working or there's some reason why I can't give it, then I might go to those medications, but those 2 medications are not my first line I would use all the time.
Okay, a couple more questions come in. So while we have a few more minutes, I'll go ahead and ask them as well. Is ketamine used in managing pediatric pain?
Say that again. Sorry, I didn't hear. Is what used in?
Ketamine.
Ketamine. Okay. Ketamine used in pediatric pain. Did I get that right?
Yes.
Okay, sorry, it cut out a little bit, Caitlin.
Oh, sorry.
Yes. Ketamine is used more and more in pediatric pain. And we used to often use it around procedures, but we now use it more often. We don't usually give ketamine at home. Usually someone's in the ICU when we're giving ketamine, and it involves, lots of meetings and people getting together and safety and starting IV ketamine if someone is having really severe pain, but it is certainly used. We sometimes also do a ketamine washout if someone's, that's very specific, but if someone's on a lot of different medications, we can't get the pain under control, we will kind of stop everything else and give high doses of ketamine IV to sort of clear out the system and reset and start medications again. So we use it more and more now, but it's not something that we use, how should I put it? We don't take it lightly when we just say, oh, let's start ketamine, right? It's considered, you have to be very safe and careful, and usually in the setting of an ICU with people who know how to do it, but it can be very effective for pain management. Yeah.
Excellent. Okay, and then looks like we have one more question. Can long-term use of corticosteroid cause diabetes in children?
Yes, technically, yes, you can get diabetes mellitus from the use of steroids in children over time. Yeah, I mean, many of these things again are over time. So it's the same thing as said before about the steroid use in children. It depends on how long you're giving it for. My background, I worked in, for example, very briefly in neuromuscular diseases for many years. And those children are on corticosteroids as part of their treatment for years. They live on them, literally. And so if they're going to be on them for 20 or 30 years, yes, they will have side effects like diabetes, lots of other things that can come from it, but it just depends on how long the use is. So if I'm using like a burst dose or a short dose of steroids to get pain under control, I'm not necessarily worried about that, but in long-term use, yes, it is a potential side effect, along with lots of other lovely things from steroids, right?
Okay. Okay, one more question. Oh, sorry, go ahead.
I just want to add that, like with all of these medications, whatever age, it's really important to think about the risk versus the benefit, right? So if steroids are the gold standard, you really do utilize them regardless of the side effects. You understand the side effects, but you make sure that the patient and family understand that you're using this as a gold standard to treat the symptom or underlying cause, knowing that you are going to have to treat the side effects.
Excellent. Okay, thank
Right.
you both.
Yeah.
Oh,
Yeah, I
sorry.
would just say, and to Renee's point, right, it depends on where you are in the illness trajectory, right? Because if you're trying to get somebody's pain under control so that they have, they're at the end of life, you're not so worried about side effects, right? So it just depends on where you are. And that's why you need to, to end on that note, right? All of this is individualized. There's no one size that fits all for this. You have to do a thorough assessment, know your patient, know what's going to work for them and the situation you're looking at.
Excellent. Well, thank you both so much. We're about up on time. Thank you everyone for staying a bit longer to have a really great Q&A session as well. Really appreciate everyone being here and appreciate both Venessa and Renee for really excellent presentations. We're getting lots of positive feedback in the chat and I second that. It was really, really informative and really great to have you both here. And as a reminder, we'll be sending recordings and slide decks and also some of the resources shared today with all attendees later this week. So please be on the lookout for that in your email. And as always, please feel free to reach out via email to me if you have any questions. Otherwise, I look forward to seeing you at our next session. Thank you both so much. Have a great afternoon.